As people come in, I am privileged to welcome you all. I'm Howard Hu, the chair of the Department of Preventive Medicine at the USC Keck School of Medicine. Welcome to Grand Rounds in Population and Public Health Sciences, our platform for convening discussions of the utmost importance to the public's health, locally and globally. Today's event is also co-sponsored by the COVID-19 Pandemic Research Center, which has been working with collaborators throughout the university, as well as with government, the private sector, and NGO partners to address the pandemic. Last week marked a significant milestone with the state of California giving the green light for easing most COVID-19 restrictions, including the reopening of most businesses at full capacity. This was a significant turning point in our battle to address and to control the COVID-19 pandemic. Today, we are joined by experts to discuss what has been COVID's impact on LA County over the past 15 months and what are the lessons we have learned, a critical exercise for continuing the fight and preparing for future public health emergencies. We are particularly delighted to welcome Dr. Barbara Ferrer, who has been leading the charge against COVID-19 as director of the Los Angeles County Department of Public Health. In this role, Dr. Ferrer oversees the department which protects health, prevents disease, and promotes equity and well-being among LA County's 10 million residents. She manages a $1.3 billion budget, directs a workforce of 5,000 staff, and works to integrate services with her colleagues at the Departments of Health Services and Mental Health. Dr. Ferrer is a nationally known leader with over 40 years of experience as a philanthropic strategist, educational leader, researcher, community advocate, and public health director. She is also the overseer of a major collaboration involving our very own COVID-19 Pandemic Research Center in collaboration with Dr. Paul Simon and Dr. Will Nicholas of the LA County Department of Public Health, which is the LA Pandemic Cohort Surveillance Project. The collaboration aligns with the aim of our department to forge ever stronger partnerships with the county as part of our vision to be a leader in urban population and public health sciences, engaged in policy relevant research and training. We also have joining our panel, Dr. Maja Mataric, Interim Vice President for Research for the University, Chan-Soon Xiang Chair and Distinguished Professor of Computer Science, Neuroscience, and Pediatrics, Dr. Jennifer Unger, Professor of Preventive Medicine and Co-Director of the USC COVID-19 Pandemic Research Center, and Dr. Daniella Meeker, Associate Professor of Preventive Medicine and Co-Director of the Southern California Clinical Translational Sciences Institute Informatics Program. Before I turn this over to Dr. Ferrer, please note that we will be fielding questions for either Dr. Ferrer or the panelists through Zoom's Q&A feature that should be at the bottom of your screen. Please use that feature to submit questions. Dr. Ferrer, I now turn the floor over to you.
Oh, thank you. Thank you so much, Dr. Hu. And I really want to extend my deep appreciation for both the invitation, but more importantly, for all of your leadership, over the past year. I want to thank, in fact, everybody, the entire team at the USC COVID-19 Pandemic Research Center for your groundbreaking work and innovative studies on COVID-19 that you've been advancing in LA County. And it's my pleasure to be here today and be joined by our distinguished panelists. I was hoping that I would present some of our data to try to cover what this pandemic looked like from the beginning all the way through now and where we're headed, and then happy to hear from our panelists and obviously take any of your questions. And before I get started, I do want to acknowledge this has been in many ways a devastating year for just about everybody across the country and really across the world. And we've learned a lot, about ourselves personally, but also about how we come together when times are really bad and help each other out. And I'm going to talk a lot about data during this, short presentation. But I want to note that behind all of these numbers are people and people's lives, and the devastation, both in terms of lives lost and livelihoods, can't go unnoticed and should never be forgotten as we sort of look back and then try to look forward. But we can go to the next slide. So I am going to be talking a lot about the numbers. As I said, what do we know about COVID-19? I want to look at disproportionality, who was most affected by the pandemic, and carry that forward into the work we're doing to get folks vaccinated, workers, visitors, and of course our residents. And then talk about what the path forward looks like, what are our remaining threats, and how we can prepare ourselves to really be able to support this full reopening while we continue to protect and value everybody's lives. And I'll go on to the next slide. So, when I talk about a staggering pandemic, these are some of the numbers that I think really contribute to this view of how hard we've been hit here in LA County. We've had over 1.2 million people diagnosed as positive with COVID-19. And we all know that this probably represents less than half the people who in fact have been infected with COVID-19. These are in fact people who were tested and whose test results came back positive. We've had, almost 100,000 people who have spent time, and for some of them significant time, in our hospitals. We've lost almost 25,000 people to COVID. And we've had almost 7 million people out of the 10.2 million people who live in our county tested for COVID over this very long 16 months that we've just lived through. This is sort of our cumulative data. I do want to say, although we are fully reopened, we still continue to deal with the threat of COVID-19. We average now about 225 new cases a day. We have about 225 people on average that are hospitalized each day. Somewhere between 5 and 10 people still pass away tragically from COVID-19 each day. And our daily test positivity, which really helps us understand how much community transmission there is at, sort of an all-time low at about 0.8%. We can go on to the next slide. This really helps us understand, sort of the trajectory around cases. And cases are important because they really drive hospitalizations and deaths. A certain percentage of people who are infected end up hospitalized, and then a smaller percentage of those unfortunately end up passing away. This trend line, as you can see, shows what we've been witnessing, back since March in terms of our cases and the kinds of actions that we were taking across the county as we continue to see particularly the increases in cases. Many of these increases in cases that you see happened pretty close to either large holidays, or they happened close to large events where many people were gathering. So you can see, we obviously started seeing increases, significant increases around Memorial Day, certainly around July 4th. That was what we call our first surge. And then, our second surge really was a fall winter surge, started seeing these dramatic increases in cases as early as the beginning of October. Remember, we had NBA championship, we had MLB, Dodgers championships, lots of gatherings, lots of people getting together. And then skyrocketing cases associated with both the Thanksgiving and the winter holidays. It's estimated that we've had, somewhere around 40% of LA County residents infected at some point since March of last year and June of this year. Again, we don't really have a firm number on that. We have, thanks to some of your colleagues, actually, some seroprevalence testing that's been done, and the state has some numbers on that as well. But you can see at our peak in December, we were averaging over 15,000 cases a day, and this went on for many days in a row. We can go on to the next slide as well. This is sort of looking across the board at what happened with cases, the correlation between cases, hospitalizations, and deaths. You can see here clearly the picture that cases rise first, followed a couple of weeks later by the start of an increase in hospitalizations, followed a couple of weeks later by an increase in deaths. And with declines in cases, a few weeks later, we started seeing the declines in hospitalizations, and further out, frankly, the declines in deaths. So we really had experienced fairly high death rates all the way through February and early March. And again, that makes a lot of sense. Lots of people ended up hospitalized for very long periods of time before, unfortunately, they ended up passing away. And therefore, we note how important it is to constantly pay attention to community transmission in cases, because this has been fairly consistent pattern of seeing increases in cases, followed by increases in hospitalizations, followed by increases in deaths. Now, obviously, with vaccinations, this picture ought to change some, and certainly we won't see as many people hospitalized, which is really great news. And we also won't see as many people pass away, even when we start seeing some increases in cases, which of course we haven't seen now, as you can see on this slide. We can go on to the next slide. I want to talk just a little bit about, who was getting infected and ending up hospitalized from COVID-19. And one thing I always like to, note is we had a lot of young children and teenagers that were affected by this virus. I know, there's a myth of, this virus did not really impact young people, particularly our children. It's just absolutely not true. They definitely weren't hit as hard. But we had about 160,000 cases, which is almost 13% of our cases occurred amongst children under the age of 18, with our 12 to 17-year-old group accounting for almost half of the cases, about 71,000 cases. They did have much lower rates of hospitalization and fortunately much lower rates of death, although tragically, but we did have 5 children under the age of 18 here in LA County pass away. I'm going to go on to the next slide. And you can also see that this has been a story of disproportionality from almost the very beginning of the pandemic. The top line there, I call it the yellow line, is the case rates for our Latinx population. And pretty much once we hit our first surge, and in every surge since then, that population has been hit the hardest, followed by Black residents, and with our Asian and white residents having significantly lower rates throughout in the surges, as well as just when we were not seeing as many cases overall. And this has been particularly glaring for our Latinx population. Easy to explain in some ways. I mean, sad story, but our essential workers disproportionately in LA County are Latinx and Black workers. This entire first part of the pandemic, when many people were allowed to go home, essential workers were not. Certainly in the early days when we didn't have a lot of good information about the virus and how we should be protecting each other from the virus. So remember, those were the days, no masks, no distancing really to speak of, very focused on trying to keep people with symptoms, sick people, out of public places and out of work sites. That strategy was, while it was all we knew at the time, was woefully inadequate and frankly misguided, as we found out just how much asymptomatic spread was accounting for transmission. and how important it was going to be to get people to be able to wear masks to protect others, and it turns out to protect themselves. But throughout the pandemic, this disproportionality has played out. Root causes of health inequities are also clearly apparent here. While this is a very specific disease, this is not the only disease, and by no means is it only one of a few diseases where we see a similar pattern of inequitable distribution of diseases, including mortality rates. And root causes are important for us to acknowledge: overcrowding, low wage workers, less resources, telling people to quarantine and isolate without guaranteeing income and places for people to quarantine and isolate was an early barrier, and in fact contributed to some skyrocketing cases. Lack of workplace protections is very apparent here, and certainly from some of our workplace outbreak data that correlates with this. Where we have a lot of low wage workers, there were few protections that were in place, even when we had health officer orders demanding those protections. But this is a very disturbing picture. We can go on to the next slide. That unfortunately translated into high rates of hospitalizations. And here again, significantly higher rates of hospitalizations among Black and Latinx residents throughout this pandemic, reflecting as well folks having more underlying health conditions in the Latinx and Black communities than in our white and Asian communities. And it turns out some of those underlying health conditions make you at much higher risk for serious illness, hospitalization, and if we go to the next slide, as you'll see, with deaths as well. So, at the height of the surge, Latinx residents were dying at 4 to 5 times the rate of everybody else in LA County. This story is one that we never want to see repeated here in LA County for any future pandemics. We've learned a lot about making sure we get in front of issues around workers and where infections are going to be spread. And we have to make sure that we put that into play now. Because I'm going to show you again some distressing trends that are continuing even as our numbers are so much lower. And if we go on to the next slide, I want to sort of get to, when you look at the trend lines, it just looks like everybody's doing great. And it's all relative, and we are all doing so much better. But these disproportionality that I talked about, it continues. And so as you can see here, case rates significantly higher, 2 to 3 times higher for Blacks than they are for whites and for Asians. Again, Latinx population, particularly around hospitalizations, and then again on deaths, also is seeing sort of much higher numbers as with Black African-American residents here in LA County. So although for everyone across the board, our rates are declining, and they declined in this 1 month period, the disproportionality is not gone. It really hasn't even narrowed as much as we were hoping it would narrow, given the low rates of community transmission. We can go on to the next slide. We also will see patterns of a disproportionality associated consistently with geographic regions. Obviously, the darker colors here on this map of LA County, all 4,000 square miles of LA County, lets us see which communities have been hit the hardest over time from the very beginning of the pandemic till now. This is a cumulative rate. For those of you who know the geography of LA County, this isn't really surprising, because we could put up some maps on diabetes, we could put up a map on prostate cancer, on breast cancer, and particularly on mortality rates, infant mortality, and we see a similar pattern of disproportionality where we actually see concentrated places in our county, often associated with lower income and less resources, hit the hardest. And that certainly is the story here. Antelope Valley, Lancaster, and Palmdale, some of our more rural areas in the Northern Valley, and certainly South Central LA and parts of East LA hit very, very hard. And we go on to the next slide. You can see that if you look at case rates by area poverty levels, you'll see this play out as well. Those top two lines, yes, it's like the orange and yellow lines are communities that have higher rates of poverty, consistently have seen higher case rates. And again, in the surge, these differences were fourfold. And again, correlate with that map that I showed you. So disproportionality, I would say, is the biggest challenge and remains the biggest challenge for us to actually really see an end to the threats that are posed by COVID-19. We can go on to the next slide. Now, clearly the game changer, there's a lot of evidence here and across the country, the game changer are our vaccines. They really account for most of the decrease that we're seeing. I mean, we've had some strong public health measures in place, certainly early on in this year. But even with reopening, we continue to see relatively low rates of transmission. We have, as you can see here, over 10 million doses have been administered. We have 5.5 million residents with their first dose. That translates to about 67% of residents 16 and older. And we have about 58% of residents 16 and older that are fully vaccinated. And this is decent. We look good compared to other counties in California, and we certainly look relatively good compared to other parts of the country. While, as you can see, there's obviously more work that needs to get done. We have about 8.3 million residents 16 and older, just if you're looking for the denominators here. So we can go to the next slide, but unfortunately, similar to the patterns around who got hit the hardest by the virus, vaccination progress is also somewhat uneven. Here, sort of the darker green colors represent higher rates of vaccination. Fortunately for us, so we have hardly any places in the county. As a matter of fact, we have only some very rural areas of the county where the vaccination rates are below 30%, and even very few places where the vaccination rates are below 45%, and obviously continue to do a lot of work in those communities. But you have some big differences. Again, beach communities, much higher rates of vaccination, well over 75% in some communities. And then in places like South LA, some parts of East LA, certainly Lancaster, Palmdale, we still are hovering around 50% rate for vaccination coverage. We can go on to the next slide. And vaccination unevenness, also persists when we look at rates by race and ethnicity. So these are folks who have had one dose of the vaccine. And you can see, again, a pretty significant difference between our Black community, our Latinx community, and everybody else. If we were looking at this data for people 65 and older, the gap would not be as pronounced. We've had a much longer time period to vaccinate people 65 and older. And there we have everybody over, I think at this point, well over 65% with one dose. But here we have work to do. And you can also see here, we don't have a huge gap by gender. We did at one time, but that has been significantly narrowed. But if you go to the next slide, it's pretty telling who's not getting vaccinated right now. So this is a slide that captures information by age and race and ethnicity. So it's age groups and race and ethnicity, racial and ethnic groups. And where I've highlighted in yellow are where the biggest gaps are. And obviously we just started vaccinating amongst 12 to 15-year-olds. So we would anticipate it might take us time, but this is where the biggest gap is, in fact, 2 to 3-fold difference here between Latinx and Black residents, and in particular, Asian residents and white residents. Continues for 16 and 17-year-olds, and then remains, 2 to 3-fold difference for Black residents all the way through age 49, sort of, and I pay a lot of attention to this because 18 to 49-year-olds are workers. So huge worry going into reopening about the fact that we have all of this disproportionality in people who are likely to be in the workforce. So if you look at the rates, for example, for white residents, 18 to 29, 57% of them have at least one dose, 62% of 30 to 49-year-olds. And then you go and you look at what's happening with Black residents, 27% of 18 to 29-year-olds have had one dose, and 38% of 30 to 49-year-olds. So when you take a look, and we don't have time to sort of go into this at sort of the relaxing of the Cal OSHA standards that were just put into place last week, you can see why people like me are hugely concerned about sort of the large numbers of people who are not yet vaccinated in the essential workforce, more than likely. This really, if we're not super careful, could lead to a whole nother wave of huge disproportionality in what we're going to see in cases, unfortunately, hospitalizations. And then while they'll be much rarer, I think we'll see it, as we already are, in deaths. So we can move to the next slide, and really just drives home sort of the message that those numbers that I showed you earlier that already are showing these gaps, while all of these numbers are really relatively low, they correlate exactly with the proportion of folks that are vaccinated. And here it's just, again, one dose. So the communities with the highest case, hospitalization, and death rates are the communities with the lowest vaccination coverage. And I'm gonna, we'll come back to this theme, as I want to close out. But I think it's really important for us to understand that, this does not represent a whole host of anti-vaxxers not coming in to get vaccinated because, they've spent their whole lives, fighting against vaccinations. This has to do with issues related to access and to confidence in these particular vaccines. And I'll talk about that a little bit as I close. But these are stark numbers, and they really need our constant attention. I'm going to go on to just a couple of sort of highlights of why vaccinations really do matter. So, the top blue line is the experience of all people on cases. You've seen this trend line numerous times in this presentation. The bottom line is what was going on with healthcare workers. And what I think is important to note is, again, everybody, when there are surges, healthcare workers got hit hard. And as a matter of fact, in the height of the pandemic, we were averaging almost 2,000 cases a week amongst healthcare workers. The decline, however, in folks, becoming infected happened much earlier for healthcare workers, and it really is correlated, almost exactly with the fact that we started offering vaccinations to healthcare workers in December. And certainly by the end of January, we had a whole bunch of folks that were actually already fully vaccinated. But even one dose gives you a lot of protection. And, whereas, at the height of the surge, we are seeing, over 2,000 cases a week amongst healthcare workers. At this point, given that, while we don't have an exact number, but we estimate that probably close to 70% of healthcare workers are fully vaccinated in LA County. We're down to less than 50 cases a week across all of our healthcare workers. And this, again, I'll take the next slide. You could see this in deaths as well, and sort of the just huge decline in deaths. So that in the last couple of weeks, I don't think we've had any deaths among, in last month, I think there have been no deaths amongst healthcare workers, or very few, like 1 or 2 deaths amongst healthcare workers. I want to also look at what happened in our skilled nursing facilities, which, as all of you know, is where we saw, sort of half of our deaths initially. We go on to the next slide. Half of our cases and half of our deaths. So first, this is cases, it was, in fact, almost all of our cases were happening with that green line at skilled nursing facilities. Did a much better job. We introduced a whole lot of testing. This is pre-vaccination. But then again, introduced vaccinations early on at our skilled nursing facilities. We did not wait for the federal pharmacy partnership. By mid-December, we started vaccinating in residents and staff. And again, you see a very steep decline in cases. And if you go to the next slide, you can see an even steeper decline in deaths. We average, again, very few deaths among our skilled nursing home residents. 80% of both workers and staff at skilled nursing facilities are now fully vaccinated and have been since March. We've seen those good numbers. So again, these vaccinations are powerful. We could talk a lot about, how powerful they are. I think these are 2 really good real examples of, just looking at current data in LA County. We could take the next slide. Just a little bit of sort of bragging. We were the worst county in the country in terms of our case rates and our hospitalization rates and death rates in December and January. We do have really solid numbers on people getting vaccinated. And I think between the natural immunity that people are carrying for some people who are not yet vaccinated, and the fact that we have pretty high vaccination rates, our case rate per 100,000 people has dropped to 1.7. Our test positivity rate last week averaged about 0.5%. It's creeped up slightly now. I think more an indication of a lot of surveillance testing at schools isn't happening any longer. But there still has been a lot of progress, and it's everybody's efforts that got us here. I'll take the next slide. The big issue for us is, how do we stay here? We haven't reached community immunity. We're actually pretty far from community immunity. We think that has to be at least 80%. And the virus is not less lethal, if anything, and we can go to the next slide. We're seeing an increase here in LA County of the Delta variant. That's that sort of yellow sliver you see on the top. It's making up almost half of the sequenced specimens cases that we're seeing. This is from about data from about 6,500 specimens over time. You can see the shift. You can see sort of that orange bar is the UK variant. And you can see now, the Delta variant kind of dominating or starting to dominate. I'll be updating these numbers tomorrow, and we have seen an increase. So, we do have to pay attention to this. For people who are not yet vaccinated, this can be a very big threat when you have a variant of concern that is more infectious and in fact looks like it's more deadly. And you have a whole host of workers at workplaces without distancing requirements and capacity limits. Partitions can be done away with. We're going to worry about really how quickly this could spread amongst unvaccinated people. The good news is, and we'll go to the next slide, is we've got data that shows that if we can get more people vaccinated, these vaccines are super powerful, as I noted. 4.4 million people who are fully vaccinated. We looked at everybody who tested positive, who was fully vaccinated, and we found about 1,696 people in this group of almost 4.4 million people who tested positive after they were fully vaccinated. We found 139 people fully vaccinated who have been hospitalized, and we have 19 people who were fully vaccinated who have died. In that group of 19, we have a significant number of folks who were immune compromised, and that is the one group for whom there is still concern around the vaccine's effectiveness. So, but all in all, if you look at this data, it's actually quite remarkable. I don't think any of us would have anticipated that our vaccines would be quite this powerful. Tests showed us, the clinical trials showed us that it was going to give us a lot of protection against serious illness and death, but it actually gives us a lot of protection against who's getting infected and therefore who is going to pass along the infections. So it's clear to us, and we can go to the next slide, that the main task in LA County is to make sure that there is very easy access to vaccines. Barrier-free access, as a matter of fact, is what we're striving for. So, no appointments, not much verification except for teens. For this week that we're in, we have 767 permanent sites that are open across the county, a lot of concentration in the hardest hit communities. These include pharmacies, clinics, hospital sites, community sites, but these are our permanent sites. If you go to the next slide, we're also very big on popping up sites with our mobile units. This week, we're at 247 sites with mobile units. This is, in fact, we're at community events, we're at houses of worship, we're at transit stations, we're at parks, we're at shopping centers. We go where people ask us to go. We go to work sites. We'll go and set up a pop-up and vaccinate 10 people, and we're good with that. We're good with this model. We keep expanding our capacity, and this is just the county-sponsored mobile teams. There are also a host of other mobile teams sponsored by other health centers and healthcare providers and cities. So this is really what we're trying to get better at. And in many cases, we accompany our mobile teams with what I'll go to the next slide, which is the strategy of building vaccine confidence. Because I think access, as I noted earlier, is one big issue, and we have to make sure that there are really no barriers to getting vaccinated. But the other is we have to build confidence. So there are lots of really legitimate reasons why people may be fearful. These are vaccines that are new. They were developed on an accelerated timeline. We think there's lots of evidence about their safety, particularly now that hundreds of millions of people have been vaccinated. But we do have to answer people's questions. So we hold a lot of town halls. Our partners hold a lot of town halls where people can ask us questions and we answer them. We partnered with over 200 faith-based organizations. Again, this is a huge effort to make sure that there's good access to information from trusted people in the community. We also have a huge community health worker outreach initiative where healthcare workers, promotoras, can go door to door, answering people's questions. It's not just giving them information about vaccines. It's actually at this point answering people's questions and getting them the kind of information that they feel would be helpful for them to make a good decision, clarifying and misinformation that's out there. We've put $67 million out in contracts to our community-based, faith-based, and healthcare partners. Again, recognizing that those that are in the community have been in service of community residents are best positioned to build that confidence. We also site in safe places and communities, and we stay there for a while so folks will get to know us. We always have a physician on our site. We set up the ability for that physician to just answer questions without people needing to get vaccinated. And then we're doing much more around personalized communications, again, using other people who are influencers to talk about their own experiences getting vaccinated so that everyone can understand that pretty much everyone who gets vaccinated has questions and concerns, and then gets those questions answered in a way that makes them feel like this is the right decision for them to move forward with. And I'll take the next slide, which is really the last slide. You know, what I just want to close with is we've gotten through this very long pandemic by really committing ourselves to taking care of each other. And this would not be the time to stop doing that, just because things are better. Because for some people, there's still a lot of risk because they're not vaccinated. That includes 1.3 million children under the age of 12, as well as you saw well over 1 million people who are older who have not yet gotten vaccinated. So we recommend that, you know, people continue wearing those masks in places where it's really crowded, that please follow the rules. If a business wants you to wear a mask, even if you're fully vaccinated, please keep that mask on. And certainly if you're not vaccinated, you need to always wear your mask. And as a matter of fact, you should be upgrading to an N95 or a KN95, a respirator, if you're going to be around a lot of people, either at work or in a social setting, especially if you don't know the status of all of those people. Again, just sensible things. If you're sick, you still need to get tested, and you need to stay away from other people, quarantining and isolation for people who are infected. These strategies need to stay in place because the pandemic is not yet over, and the disproportionality can actually widen if we're not super careful in our reopening. And thanks so much and for having me, and happy to go ahead and listen to our panelists. And I'm anxious to hear from them. I think you're on mute, Howard.
Thanks, Barbara, for that tour de force. First, let me just say that there's a lot of questions that have been put in the Q&A that I hear from good sources that you're willing to stay a bit longer. And I think we'll try to keep this event going past the 1 p.m. hour so we can get to many of the questions. Now I'm going to turn to the panelists, each asked to give a response, and they're also invited to give a question. We'll start off with Professor Mataric.
Well, first of all, Barbara, thank you so much, both for the work you have done and especially for the transparency, for sharing the data to keep us all informed. So I know as a university, we worked very closely with the County Department of Health. And I don't think it's always clear to people who gets to make the decisions and how much this is always an ongoing dialogue and work in progress. So I really appreciate that. I will say that as a university, we have, led some of the demographics. We've had some incredibly diverse responses, right? So we see, for example, vaccine hesitancy in some groups and then extremely high vaccine response in others, right? Because we as a large employer, we have staff, we have faculty, we have students. We have seen 0 transmissions in the context of research, and yet we have seen, of course, high transmissions among students back when students were still around, right? And so it's such a challenge to look at it from a large organizational perspective. And so I appreciate looking at it from the perspective of an entire, county, and well, at least it's worse there. So that's been an ongoing challenge for us. I will say that as a large organization, we also feel pressures, right? I'm hearing from researchers who say, hey, we're all vaccinated. Why do we need masks? And on the other hand, of course, from the numbers that you have shown, it's so very clear why we do. So I think that communication is just really critical. It's an obvious thing to say, but it has been the challenge, right? To get everyone just know what's the bottom line. Who do we listen to? And so this is really helpful. I can't thank you enough for the numbers and for the leadership and just for the transparency around the situation where everyone is to some degree confused and worried. So thank you so much.
Thanks, Maya. I didn't hear a question in that, but that certainly was the kind of response.
I actually think well, I will say that I think there's some good questions about next steps in the webinars. Ask them obviously about boosters. I think the questions are already in there, so I will seed those.
Okay, super. Jennifer.
Thank you so much for this webinar. It's been very interesting and informative. I'm curious what the plans are to when kids return to school in the fall. This will be the first time that we're having a large number of kids together in schools, and we've done some qualitative research with principals, teachers, parents, and students. It seems like the principals are very eager to get started. They feel like they have their safety procedures in place. The teachers and parents, not so much. They're a little worried about returning, worried about how the logistics are going to work, and worried about the long-term effects on the students. So I'm curious if there are plans to do some outreach to schools, maybe doing testing in schools and vaccination at schools, because that's a place where families will visit every day, and it's in the community that's trusted by families who might not want to access a more official government organization.
Yeah, it's a great question. So we have probably 200 staff people that are assigned to work at schools and have been working at schools all along. So we have deep relationships that I meet pretty much once a week with all of the superintendents of the 80 district schools. We have a special relationship with LAUSD, have actually embedded a staff person there full time to really help make sure that we're being attentive and able to be supportive. So all along, we've been working with schools, and many schools reopened in the early spring, and every school that reopens in LA County gets a visit from our technical assistance team here that works with the school to make sure that they're able to adhere to what were the reopening guidance. That reopening guidance is still there. It's shifted, obviously. And you ask great questions about what will it look like in the fall, because it will look different in the fall. But there still is a masking requirement for everyone indoors at school. So I want to start with, at this point, where we are right now, there's a requirement indoors at schools. Everyone has to stay masked regardless of vaccination status. We've been vaccinating at schools. Every single district had a partner. 3 of the districts were their own vaccinators, but all the other 77 school districts had a healthcare partner that was there to vaccinate teachers and staff. So we've had a lot of experience vaccinating teachers and staff early on when vaccine became available for people in the education sector. And at many of our sites, I believe we have 120 schools that serve as community vaccination sites. So obviously we agree with you 100%, super important to be in the schools. They are trusted. People will be there. Their kids are there. So part of this was really switching everyone also to Pfizer so that we could vaccinate the teenagers at the schools. But all the schools that vaccinate are vaccinating students, staff, and community residents. So these are all sites that really try to be, as you noted, and I think you're so right on this, places that people will go to and people trust, and they can get access to good information as well. So that, and the third part of the partnership is outbreak management. So we always will, and we'll see this later on as well. We'll always have cases at schools. If we're all doing this work well, they don't translate into large outbreaks, and that in fact was the reality. We had tens of thousands of teachers and really over 100,000 students, well over 100,000 students back in school already, and we saw very few outbreaks at schools. I mean, when the community transmission is high, you obviously have cases because people are testing and they're testing positive, and then we're doing all of the contact tracing, and we had stable groups, so there wasn't, it wasn't spreading. The largest outbreaks we've had at schools have been associated with school sport teams that were traveling. So not even with activities in the schools. And we have a huge partnership with LA County Office of Education on a host of things, but including testing. So there's about 300 million $300 million that's been allocated to most of it to LA County Office of Education that gets distributed to all the school districts to make sure that we did some of this already in June, but certainly as schools start reopening, that there is testing available depending on what the school district decides they want for testing. And again, working closely with labor partners, I want to acknowledge and thank all of the labor partners that have been involved in schools, because we've had a good partnership, and they're raising really important issues that then get resolved through the contracts to make sure that there's a lot of protection. We also have a parent and student ambassador program at the school. So we train parents and we train students so that they know what a safe environment should look like. They have a voice, they can raise issues and concerns, but they can also talk to each other. And this has been really useful around vaccinations as well. So we do have this ambassador program. It's an online program. We've had hundreds of people participate in it, and we'll continue to roll that out when schools reopen. So there's a good partnership there, because we think it's super important that schools are open in the fall, but that everyone feels safe when they go there.
Mm-hmm. Thank you so much.
Hey, Daniella.
Thank you again for such a fantastic presentation and your fantastic work with all of this. You really have shown sort of how this can be successfully managed, even with such a huge
I have an
portfolio.
amazing. So.
It's very impressive, and your point on disparities, it really hits home. I think all of us are very concerned about this kind of thing, and you alluded a little bit to how access to care may be a driver of some of the outcomes. And in thinking about that, I was really struck by the $67 million investment that you guys are making in presumably non-healthcare settings that might actually expand from what our typical model is, sort of having the health system be the nerve center for all of this. Do you guys have plans to extend that infrastructure into the future, both for outbreak management, like you described in schools, as well as surveillance and even prevention of other conditions?
I mean, it's a great question. I mean, obviously, we're using some of the money that we get from the federal government to push it out to our partners, and some of those partners are our healthcare clinics. I want to say, federally qualified health centers and our small community clinics, those are already folks that do way more than just provide healthcare, or well child care or sick care for people. They often have a ton of programming for community residents that really is about, promoting optimal health and well-being and aligning resources to make that possible. A lot of our partners are really supporting making sure people have food, that they have access to housing. We did, stand up what we call quarantine and isolation sites, where people who can't successfully isolate at home, either because it's too crowded or because they don't have a home, can go and, they're hotels essentially, and they'll stay there for their isolation and quarantine period. So, our partners are really helping to connect people to all of these services and resources, but also give them good information about taking care of themselves, about participating in contact tracing, about isolating and quarantining, about accessing the kinds of resources that you need to really be able to thrive in any environment, but certainly really to be able to be Seattle. So we'll continue that. We've always tried to figure out ways to make sure that resources we have are shared with our community partners, and we believe strongly in the fact that it's community-based organizations, including faith-based organizations and the health centers, that are the backbone of promoting health equity and making sure that there's an alignment with what we say, resources and opportunities that need to be in communities in order for people to be well. So we're going to continue that work. Whether we'll, have $67 million in the future, I'm not really sure, but we do have a strong commitment, and we're extraordinarily grateful and blessed to have all of these partnerships.
Okay, like I said, we've received a lot of questions. We're going to go over the 1 o'clock time period. So I'm going to pose a couple of the questions, and then I'm going to ask folks to stay on if they can, and thank the panelists. But there's so many questions, it's amazing. But let me try to curate them. A number of questions have been related to this particular theme. Regarding the issues surrounding vaccine access among essential workers, there's a lot of folks who believe that there are barriers to receiving time off from work to get vaccinated, or worried about missing work due to side effects. Are there any specific policies or measures to address this particular barrier and support these folks to get vaccinated?
Yeah, I think it's a huge, huge issue on the policy side. And obviously, the most important thing that we all could do right now is pass paid sick leave. Like, everyone should have paid sick leave. And not just because, of COVID. I mean, paid sick leave would help us when we have flu floating around. We're one of the only countries, developed countries in the entire world, that doesn't offer paid sick leave. And it has hurt us in terms of people being super worried about the side effects, and feeling like, if I'm not feeling well and I have to go to work after I get vaccinated, how's that going to be possible? So I completely agree with you. It is a policy shift. Obviously, we work closely with a lot of the businesses and the employers, and we've asked them to allow people for paid time off, without a policy. We've asked them to also free people up and pay them to go get vaccinated. And we've had a lot of businesses that have been super good about this. We also will go to any work site. We offer that to businesses. If you want us to come to your site, if you have 10 people that you think might want to get vaccinated, we have a form online, or call us up. We have a call center, and we'll send a team to vaccinate workers. But I think you're right that, ultimately it is a policy decision that makes it really easy for people in this circumstance and other circumstances when you're not feeling well to stay home. That was huge. Obviously we have a new Leave Act that protects people who become ill with COVID, but it's limited. And people have pointed out to us that for people who've had COVID more than once, it's been hard to be able to use that policy. But I want to thank the state and the governor for all that they've done already. But we do need paid sick leave for everyone, not just for COVID related illness. So I think that will help.
Thank you, Barbara. Here's another question related to access. Can we do something that would enable 12 to 17-year-olds to get vaccinated without parental consent through something like state legislation, the way we do it now for HPV?
Yeah, it's a great question. And obviously we would need legislation to do that. But I want to note that we've tried our best to make it easier on parents. And these would not be parents who don't want to give consent. These would be parents who cannot come with their teenager to get vaccinated. So we have forms online that can get filled out. We will call parents and have them text us their consent if somebody shows up without that consent form. So for parents who are allowing their teenagers to get vaccinated, we're making it as easy as we can at the sites, certainly at all of the county sites. But I think you raised this issue, and certainly we've heard from teens in some of our teen town halls that their parents don't want them to get vaccinated and they want to get vaccinated. In those situations, if you're not an emancipated minor, you do need to wait until there is some state legislation that would support this. It would be pretty hard. I mean, we're also, when teens talk to us, I mean, we're also happy to talk to parents. So, we offer that to teens that, we're happy to connect with your parents. We're happy to send a community outreach worker to try to give some information and answer questions. A lot of times parents just have a lot of questions that need to get answered. And we try to encourage people to be respectful of that process and to be respectful of a parent's right to get those questions answered.
Here's another question. Given the disproportionate impact on people of color and essential workers, is it an option to have the county require workplace vaccination?
Well, it's an option for everybody. I mean, USC can require, and as I think you will require some vaccinations. So everybody has that option. Private business will have that option. Certainly, public businesses will have that option. We're all, I think many of us are waiting for there to be full approval. It's hard to mandate a vaccine, except in some specific settings. Healthcare would be one of them. That's under an EUA. So we're looking forward, and we think that will happen this summer, at least for Pfizer, and then follow closely after that for Moderna to get full approval. But yeah, that is an option. I mean, I would say, I think the most important work right now is building trust and confidence in the vaccines. And there are some settings where it's super dangerous, healthcare settings, hospitals, for example, where those mandates might really be more appropriate earlier on. But I would say in general, I think the strategy right now has to be respectful, to listen carefully, to answer people's questions, and try to build confidence.
I can see that a lot of people are still staying on, so we're going to keep going. Any thoughts about why the most recent statistics show that Blacks are more disproportionately affected now than Latinx?
Yeah, I think that slide that I showed that showed who's getting vaccinated is probably a good part of the answer. So the lowest vaccination rates are among Black residents now. So this is the first time that we're going to see Black residents have higher case rates, hospitalization rates, and death rates. Because up until now, that has not been the story. But I think now that we know how much protection vaccinations are providing, it's really going to correlate almost exactly with the number of cases, hospitalizations, and deaths that are going to follow. So where you have higher vaccination rates, either in geographic areas or in population groups, you're going to see less cases for sure. And where you have those lower vaccination rates, we have to work really, really hard to do two things at the same time: build confidence and make sure that the public health measures that frankly got us through the first 9 months, 10 months of the pandemic, those need to continue for people who are not vaccinated. It's a little bit my frustration with Cal OSHA, being so quick to strip away distancing requirements. I get the need for places to reopen, but if you've got people working on an assembly line and you can look at this data and see that you might have 50% of your workers not yet vaccinated, they all need to be given offered the respirator. They shouldn't have to ask for them. That might work well in a unionized setting. I don't know how well it's going to work in a non-unionized setting. And those partitions that are there when people are going to be super close to other people for long periods of time, they should just stay there. That's not impeding the work from getting done. I'm a big proponent of allowing our businesses to get back to doing their customary operations, but there are some sensible steps that we could be taking to protect workers that I think we've lost an opportunity. I think we should require partitions where there's going to be close contact, and employers should be obligated to offer all unvaccinated workers face covering, and there should not be any self-attestation at workplaces. People should have to show, if they're going to take their face coverings off, it should be because they can show that they are in fact vaccinated. Just to offer all that protection. I mean, we don't want our work sites again to be places, as we saw in the beginning of this pandemic, places where people are more likely to get infected. And we know from what we saw in March, April, and May that then you have work site exposures that are going to translate back into the communities. Workers who have to be at work in these crowded conditions, who are not vaccinated, are going to go back into their homes. And let's remember, all those kids under 12 cannot get vaccinated yet. So you can have unintended consequences here that I believe none of us would like to see.
This next question is exactly the reason why our center and many other investigators have started to embark on what's called now the epidemiology of disinformation, which has been such a critical factor on why the pandemic has spread. So the question is, What do I say to people who tell me they don't believe the COVID death numbers and it's all a hoax?
So I think, as with most of the false information, although certainly not all of it, there's some kernel in there that there's some truth to it. It just gets exaggerated and used incorrectly and inappropriately. So this is one of those cases where there was confusion about the definition of when a death is going to count as a COVID-19 death. And some places were not using the CDC definition, and I think that contributed to the confusion. But we are, we use a standard definition. That's the definition that CDC has provided, that basically says, people who die 60 days out after having COVID will be considered a COVID-19 death. So I think there is a reality to this, that oftentimes people are sick as well with other conditions that may contribute to the fact that they passed away. But there is a standardized definition, and all you had to do was sort of be in the hospitals to see that, pretty much every number that we're counting are people who really got seriously ill because they had COVID-19, exacerbates your other underlying health conditions. So, if you're a person who had asthma, or you're a person who, suffered with obesity, these were things that really, increased your risk of serious illness. But COVID-19 was the contributing factor. And if anything, I'd be honest to say that at the beginning of the pandemic, there was a lot of undercounting. People, remember, we couldn't test people.
Right.
We didn't really know who was dying. We didn't even know who was really sick. We had no capacity to test people. So, I think for those folks that are worried that this is overrepresenting the number of deaths, it's probably actually underrepresenting the number of deaths.
Okay, I'm going to pose this as the last question before we close. What's the likelihood that LA County residents will need vaccine boosters in the future? And if we do, is there a plan? Would it be up to the individual to make appointments, or would individuals be contacted by the department to schedule vaccine boosters? What do you foresee?
Yeah, so of course we're planning for vaccine boosters, whether it's, this year or next year. I mean, I don't think it's likely to be this year for most people, but the researchers and the scientists are going to tell us when we need boosters. And, one reason why we track so carefully on breakthroughs is, it's really important to know what those breakthrough rates are. And when they start increasing, we have to start looking around at what might be causing the increase. Is it vaccines are waning? Is it there's a variant that the vaccine's not protecting us from? So, I report every month on sort of what do we know about breakthroughs. And the good news is, for the last 3 months, the rate has stayed very stable, which means that these vaccines continue to provide a lot of protection. But if there is a time where they don't, we are prepared for boosters. I mean, a lot of things are in place because of our experiences over the last year. Certainly, doing a good job, because we're always going to need some community sites to make sure that in those neighborhoods where there's not easy access to medical care providers, we're there very quickly early on with access to any kind of boosters. But the reality is, with most immunizations, if this becomes a regular event akin to flu, you want to make sure that your healthcare system can actually handle this and handle this well. And for many people, they'd actually rather go to their provider and get their vaccinations. They usually trust their provider. They know their provider. And the vast majority of people have a primary care provider or a specialty care provider that they would like to go to. The process was made more cumbersome this year because people had to, if you were a provider, you actually had a whole special enrollment process you had to go through to show that you could manage the cold chain requirements. So we're trying to work that out now, get as many private practice providers enrolled in the federal and state vaccine provider program so that we will be prepared and be able to actually offer vaccinations through the existing healthcare system, supplemented by community sites that would pop up in communities that don't have good access. But our pharmacies, our work with our pharmacies over the last year has been essential, and they have been wonderful. They're open extended hours. They're almost in every community. This is also independent pharmacies, not just chain pharmacies, and I think that will help us. We're building a huge infrastructure at schools because the first job we're actually going to have is to vaccinate younger students. So I would imagine this fall there's some kind of approval for the vaccines to be able to be used for maybe 5 to 11-year-olds. And we want to be able to have a system at schools that makes that as easy as possible. So yeah, I wish I could say like everyone gets to go on vacation for a little while, and because everything's in place, but this team here is continuing to really work super hard with all of our partners, including you, to get ready for both boosters, vaccinating younger children, and making sure that we continue to use those public health measures for mitigation when they're appropriate.
Barbara, thank you very much. There's still a long list of questions. We're going to preserve them, forward them to your office so you get a sense of what's out there, what people
We'll
are thinking
answer
about.
them. We'll actually send you back responses. I'm really
Okay. I mean, there are questions about kids under 12, lots of concern about the Delta variant, on and on.
Yeah.
But you've been so gracious to stick with us, and we'll probably have to have you back on our programs. I sense sometime perhaps in the fall.
That would be my
for all of us. We've all come a long way in fighting this pandemic, especially as Manuel Pastor, one of our colleagues, has said, this is the disease that is, or the illness that has uncovered the disease, which is the health disparities for which we're all susceptible to, particularly subsegments of our society. Our Pandemic Research Center will continue the fight in filling important gaps in research. Our hope is to reduce those unequal impacts, and we welcome partners to join us in this research effort. Of course, we also have a philanthropic arm. We're welcome to get your contributions, but sign up for our mailing list also, and please keep a lookout for our future events. And after that, I must thank you again, Barbara, and our panelists, Maja, Daniella, Jennifer, for joining us. And for all of us who are still on, we've had still a remarkable 3/4 of our participants staying on for this extended session. We'll see you next time for Grand Rounds in Population and Public Health. Bye now.